So, I want you to just take a second and think about your typical day. Like maybe you're someone who actually gets after it, right? You spend 45 minutes sweating on a spin bike or, you know, grinding through a heavy lifting session at the gym.
Which is great,
Right,
obviously.
it's great. And you probably think, well, my joints and my cardiovascular system are protected for the day. Like you check that box and you're good.
Yeah, that's the standard way we've all been taught to think about it.
Exactly. But according to the newest, like most sweeping medical consensus to come out of Europe recently, the way you spend the next 10 hours like sitting in your office chair or just relaxing on the couch, it's quietly dismantling a huge chunk of that hard work.
It really is. It's kind of alarming when you look at the data.
It's wild. So today we are doing a deep dive into the other 23 hours and 15 minutes of your day. We're breaking down the brand new 2025 EULAR recommendations. And EULAR that stands for the European Alliance of Associations for Rheumatology, right?
Yep, that's right. And this update, I mean, it completely overhauls how the medical community views physical activity, specifically for people dealing with things like inflammatory arthritis and osteoarthritis.
Which is a huge portion of the population.
Oh, absolutely massive. And this is a monumental shift in the clinical landscape. We're looking at a synthesis that was just published in the Annals of the Rheumatic Diseases, and they didn't mess around. They pulled together over 50 systematic reviews.
Wow, 50.
Yeah, 50, plus 30 randomized controlled trials and like 25 qualitative studies.
So this is incredibly comprehensive.
It's definitive. The entire paradigm has just moved away from this outdated concept of simply prescribing exercise, like, treating it as a localized mechanical fix for a bad knee.
Right, like do these 3 stretches and your knee is fixed.
Exactly. Now, the focus is on managing the complete 24-hour physiological environment of the human body.
And the stakes here are just so high. Like whether you are personally managing chronic joint pain, or maybe you work in a health profession, or honestly, if you're just tracking the cutting edge of movement science.
True.
EULAR is basically forcing us to stop looking at movement as this binary state, right?
Yeah, that binary of like working out versus resting.
Right. And instead, they want us to look at the distinct, often kind of insidious biological states that we cycle through all day long.
Insidious is the perfect word for it, actually.
Because if we look at overarching principles, 1 and 2 of these new guidelines, the fundamental baseline shifts completely. They are treating physical activity and sedentary behavior as 2 totally separate, independent physiological variables.
Yeah, and the scientific community has drawn a very hard line here. They were heavily influenced by the 2020 World Health Organization guidelines, which EULAR has now fully integrated into rheumatology.
Okay, so to understand the gravity of this, we really have to look at the basal metabolic rate, like how scientists actually measure energy.
Right, they measure energy expenditure in METs, that's METS, which stands for Metabolic Equivalence of Task.
Okay, and a MET is basically what?
So 1 MET is literally just the energy you burn while sitting quietly, just breathing, doing nothing.
It's keeping the lights on in the body.
Exactly. And the new guidelines define sedentary behavior as any waking activity that keeps your energy expenditure at 1.5 METs or lower.
While you're sitting or reclining, right?
Right. You are awake, but your skeletal muscles are essentially dormant. They aren't doing anything. And physical activity is defined as literally anything above that 1.5 MET threshold.
So, I mean, reading this, it sounds a lot to me like the relationship between diet and sleep.
Oh, that's an interesting way to think about it. How so?
Well, like if you eat a perfectly balanced, nutrient-dense diet every single day, which in this analogy represents your 45-minute workout.
Okay, yeah, tracking with you.
But then you only sleep for 2 hours a night. That perfect diet doesn't magically negate the severe biological damage caused by the chronic sleep deprivation.
That is a phenomenal analogy, yeah.
Right. Like hitting the 150-minute weekly target for moderate exercise, it doesn't just give you a biological free pass to remain in a 1.5 metoni state for the rest of your life.
That framing really captures the severity of it because the legacy public health message for decades was essentially an accounting trick.
An accounting trick.
Yeah, like earn enough exercise credits to buy off your sitting debt.
Oh, wow. Yeah, I went for a run, so I earned the couch for the rest of the Sunday.
Exactly. But the clinical data shows that prolonged sitting triggers entirely different physiological pathways. And these pathways are completely independent of your cardiovascular fitness.
So even if you're a marathon runner, sitting for 10 hours is doing its own specific damage.
Precisely. When you remain at or below 1.5 mTs for extended periods, the large skeletal muscles in your lower body, they effectively just shut off.
So you just go to sleep.
Yeah. And because they're shut off, they stop demanding glucose from the bloodstream. Blood flow stagnates, the endothelial function in your blood vessels decreases, and your body's ability to process fat drops precipitously.
And I imagine for someone managing a systemic autoimmune condition like rheumatoid arthritis, that's disastrous.
Or a degenerative condition like osteoarthritis, yeah.
Right, because that metabolic stagnation, it's basically pouring gasoline on a fire. We aren't just talking about getting stiff from sitting too long.
Oh, no.
We are talking about creating this environment where systemic inflammation just thrives, right? Because the metabolic engine that usually clears out those inflammatory cytokines is just idling.
The clinical outcome is highly concerning. The data shows that high amounts of sedentary behavior independently contribute to higher all-cause mortality risks.
That's terrifying.
And it leads to significantly worse disease activity outcomes in inflammatory arthritis.
Which is exactly why overarching principle 2 is so disruptive.
Exactly. It states that reducing sedentary behavior has vital health benefits, even if your overall physical activity level never even reaches that traditional exercise threshold.
So basically, you cannot out-exercise a sedentary lifestyle.
You really can't. The math just doesn't work that way biologically.
Which brings us to a really practical, tactical shift in these 2025 guidelines. And I found this part fascinating. For the longest time, the dogma in fitness and even in physical therapy was this 10-minute rule.
Oh, yeah, the classic 10-minute bout rule.
Right. The idea was that if a bout of movement didn't last for 10 uninterrupted minutes, it just didn't count towards your health markers.
Like it didn't exist.
Yeah, if you just walked to the printer and back or walked to the mailbox, it was treated like a rounding error. But EULAR and the WHO have officially abolished that rule.
Totally scrapped it.
Yeah, they're leaning heavily into this concept of exercise snacks.
I love that term. And the abolition of the 10-minute rule is incredibly empowering.
Especially for this specific patient population, I'd imagine.
Absolutely, particularly for a population managing chronic fatigue and joint pain. Because the science now demonstrates that microdoses of movement are biologically potent.
Microdoses. So we're talking about intermittent bursts lasting anywhere from, what, a few seconds to a couple of minutes.
Exactly. Just standing up to do 5 squats or even just pacing the room while you're on a phone call.
Just that little bit of movement does something.
It demands an immediate spike in energy from those dormant leg muscles we talked about. It re-engages the metabolic engine, spikes your glucose uptake, and it actually breaks that prolonged inflammatory cascade of sitting.
That is so wild to me. Just a minute of pacing breaks the cascade.
It's a physiological reset.
But, introducing this concept of constant movement throughout the day, it forces us to confront what is probably the biggest psychological barrier in this entire field.
The wear and tear myth.
Yes. The myth of wear and tear. I mean, think about it. If someone has osteoarthritis, where the cartilage in their knee is visibly, demonstrably breaking down, or an inflammatory condition where their own immune system is attacking the joint lining,
Right.
telling them to move constantly. I mean, it sounds to a layman like telling someone to drive on a flat tire.
It sounds reckless, yeah.
The instinctive, totally logical assumption is that more mechanical loading just equals more physical destruction.
It is the most pervasive, paralyzing misconception in all of rheumatology.
Paralyzing is a good word for it. Because people become terrified to move.
Exactly. The wear and tear model assumes the human body is an inert machine, like a car tire. A car tire grinds down because rubber cannot heal itself, right?
Right, it just wears away until it's bald.
But human joints, the bone, the synovial fluid, and even the cartilage there are living, highly dynamic tissues. They actually require mechanical loading to survive.
Okay, so it's less like a car tire and maybe more like a sponge.
A sponge is a great analogy.
Because cartilage doesn't really have its own active blood supply, does it?
No, it doesn't. It's a vascular.
Right, so it relies entirely on the physical compression and release of movement. Like literally squishing the joint down when you step and letting it expand when you lift your leg.
Yes, that physical pumping action.
Because that action flushes out the metabolic waste and pulls in fresh, nutrient-rich synovial fluid. So if you sit completely still, because you're trying to protect the joint,
You are effectively starving the tissue. You are drying out the sponge.
wow, you're trying to save the joint, but you're actually starving it.
That's exactly what's happening. And this is why Recommendation 1 and Overarching Principle 3 in the guidelines are so incredibly definitive.
Because they looked at the safety data, right?
Extensive safety data. Decades of trials. And EULAR states explicitly that there are 0 disease-specific contraindications for physical activity.
Wait, 0?
0. There is no form of osteoarthritis or inflammatory arthritis where the disease itself means a patient should broadly avoid physical activity. The general recommendations are highly applicable, safe, and effective for everyone.
Okay, but I have to play devil's advocate here.
Go for it.
The safety data makes sense to me for, like, a slow, controlled walk or a gentle water aerobics class. But the EULAR guidelines didn't stop at gentle movement.
No, they did not.
The systematic reviews actually included data on high-intensity interval training, HIIT, for patients with active rheumatic diseases.
Yeah, that tends to raise some eyebrows.
I mean, that is where I imagine the clinical pushback gets really intense.
Yeah.
Because if a patient is experiencing a severe rheumatoid arthritis flare and their knee is visibly swollen,
Right, hot to the touch. Very painful.
agonizingly painful, prescribing high-intensity training to that person just seems, well, it seems completely reckless.
It definitely seems counterintuitive until we decouple the cardiovascular system from the localized joint pathology.
Okay, explain that decoupling.
Well, the studies investigating high-intensity training loads in this population, they found no higher dropout rates and no serious adverse events compared to the control groups.
Really? None?
None. Furthermore, these high-intensity interventions did not accelerate joint destruction, and they didn't trigger systemic flares. The key here, and this is crucial, lies in Recommendation 5, which mandates individual adaptation.
Adaptation. Okay, so adapting the movement doesn't mean abandoning the intensity.
Exactly. It just means shifting the mechanical load.
So if the knee is actively flared, obviously you don't do plyometric box jumps.
Right. Please don't do box jumps on a swollen knee.
Instead, you isolate the affected joint with gentle, low-intensity range of motion work. Just to keep the sponge squeezing lightly, right? Keep it fed.
Keep the cartilage fed. Exactly.
But you still tax the cardiovascular system to its upper limits using something else, like an upper body ergometer or a hand cycle, or even battle ropes.
Battle ropes are fantastic for this.
Because you are still demanding massive metabolic output. You're driving cardiovascular adaptation and you're flushing the system. But you aren't grinding the inflamed knee.
You nailed it. And the clinical utility of this approach is backed by a very specific heuristic in the guidelines. They formalized it to help patients navigate the fear of pain. It's called the 24-hour rule.
The 24-hour rule. Because when you're dealing with chronic pain, it's got to be incredibly hard to distinguish between normal, healthy soreness and actual damage rate.
It's one of the biggest challenges. Patients struggle to tell the difference between the delayed onset muscle soreness that literally anyone starting a workout program gets.
Right, standard DOMS.
Yeah, DOMS. They struggle to differentiate that from a pathological exacerbation of their arthritis.
So how does the 24-hour rule help with that?
It provides a very concrete diagnostic boundary. Let's say a patient does a heavy resistance session. They wake up the next day and their quads and hamstrings are sore.
Just general muscle soreness.
Right. That is cellular adaptation. That is the muscle getting stronger.
Which is good.
Very good. But if they experience an acute increase in localized joint pain, like deep inside the knee joint or the hip capsule, and that specific joint pain persists for more than 24 hours after the session.
Then they've crossed the threshold.
Exactly. The body is signaling that the mechanical load or the volume was simply too high for that specific joint, and it needs to be dialed back for the next session.
I love that. It totally transforms pain from this terrifying reason to just stop entirely.
Right, into a data point.
Yeah, simple data point for calibration. It gives the patient an objective measure to modulate their own dosage.
It empowers them.
And knowing how to modulate that dosage leads right into the actual clinical mechanics of these guidelines, like how a doctor actually prescribes this stuff.
Yes, the prescription phase.
Because Recommendation 3 outlines the 4 domains of physical fitness that need to be targeted. You've got aerobic fitness, flexibility, neuromotor performance, and muscle fitness. Now, most people understand aerobic work, like cardio, and flexibility, like stretching, but I noticed a really specific shift in the language. The guidelines updated the term from muscle strength to muscle fitness. That feels like a crucial nuance.
It's a huge nuance. It represents a shift from a very one-dimensional metric to functional reality.
What do you mean by functional reality?
Well, muscle strength technically measures pure maximum force. Like how much weight can you lift for one repetition?
Like a 1-rep max on a bench press.
Exactly. But muscle fitness encompasses strength plus endurance and power.
Okay, break those down for me. Endurance versus power.
Endurance is the ability to sustain submaximal force over a period of time. So think about carrying heavy groceries up 3 flights of stairs without your muscles failing halfway up.
Right, okay. And power.
Power is the ability to generate force quickly, explosively.
And that's critical as we age, isn't it?
It's what prevents a catastrophic fall.
Right. If an older patient with osteoarthritis trips on a rug, pure raw strength isn't going to save them if they can't contract the muscle fast enough.
Exactly. They need the explosive muscle power to shoot their leg forward to catch themselves.
And they also need the neuromotor performance, right? That was another domain.
Yes. Neuromotor performance is basically the brain's proprioceptive map of where the joint is in space. It's the balance and coordination required to actually stabilize that catch once the foot hits the ground.
Wow. That makes so much sense.
Yeah.
That is why a comprehensive routine has to train the nervous system's reaction time, not just the physical size of the muscle tissue.
You have to train the brain-body connection. To map out a routine that hits all these domains, competent healthcare providers use something called the FITT-VP framework.
That's outlined in Recommendation 7, right?
Yep, FETT-VP. It stands for frequency, intensity, time, type, volume, and progression.
That's a lot of variables to juggle.
It is. And to even begin this process, the guidelines recommend starting with a standardized screening tool. The one they highlight is the physical activity vital sign.
Okay, but let's pause here and look at the immense friction of actually applying a structured, rigid FEITT-VP framework to a complex autoimmune patient.
It's definitely not as simple as handing someone a spreadsheet.
Right, because if a rheumatologist attempts to measure the intensity variable using standard metrics, like, say, a target heart rate zone.
Oh, the data is going to be wildly skewed.
Completely. A patient with active inflammatory arthritis often experiences profound systemic fatigue. Their perceived exertion could be at a 9 out of 10 just walking across their living room.
Even if their heart rate is only like 110 beats per minute.
Exactly. Standardized intensity metrics completely fall apart when the immune system is actively draining the battery.
This is exactly why overarching Principle 4 is arguably the most critical implementation strategy in the entire document.
And that principle is shared decision-making, correct?
Yes, shared decision-making. Because a rigid, top-down FETT-VP prescription based purely on biomechanical ideals, it will fail instantly if it ignores the patient's lived reality.
The doctor can't just dictate from on high.
No. The clinician has to negotiate the prescription based on the patient's specific etiology of pain, their current fatigue levels, their schedule, their preferences, everything.
The contrast between different conditions makes this so clear. Like, imagine a FETT-VP plan for a rheumatoid arthritis patient who deals with really unpredictable systemic flares. Okay. You might keep the time variable extremely short, right? But use a high frequency. So prescribing dozens of 2-minute exercise snacks throughout the day.
Yes, to avoid crushing an energy system that's already completely depleted.
But conversely, a patient with localized knee osteoarthritis might have plenty of systemic energy. They aren't fatigued, but they have severe mechanical pain in the joint.
Right, different problem entirely.
So their prescription hinges heavily on the type variable, utilizing deep water running in a pool or stationary recumbent bike.
To completely offload the joint weight.
Exactly. Offload the joint, but then you can push the time and intensity variables super high because they have the energy for it.
That clinical asymmetry where a doctor just hands down a generic printout and expects blind compliance, these guidelines actively dismantle that.
Good, because it never worked anyway.
But recognizing that even the perfect, customized plan still requires the patient to execute it in isolation, well, that brings us to Recommendation 9.
And this is where the psychology comes in.
Heavily. Recommendation 9 mandates the integration of behavior change techniques, or BCTs.
Because bridging the chasm between knowing you should move and actually getting up and doing it when you are exhausted and in pain, that requires more than just a pep talk from your doctor.
Much more. A pep talk wears off by the time you reach the parking lot.
Right. So BCTs, they aren't just vague encouragement. They are specific, heavily researched psychological mechanics.
Very specific. The core interventions involve self-monitoring, goal setting, action planning, getting feedback, and problem solving.
It's really about engineering your environment, right? Engineering it so the default action becomes movement.
Action planning is a perfect example of this kind of engineering.
Give me an example of how that works.
So instead of a vague goal like, I will reduce my sedentary time today, which is useless.
Yeah, you'll forget that by lunch.
Exactly. The clinician helps the patient formulate a highly specific trigger like, When my 2 o'clock virtual meeting ends, I will immediately stand up and walk to the kitchen for a glass of water.
Oh, so you tie the desired behavior to an existing unavoidable anchor in their daily routine.
Precisely. The meeting ending is the trigger. The walk is the behavior.
And once that action is planned out, the self-monitoring and feedback loops are what actually cement the habit over time.
Yes, and that leads us to one of the most substantial updates from any previous iterations of these guidelines.
Which is recommendation 11, right? The deep dive into digital technologies and wearable activity trackers.
Yep. The smartwatches, the fitness rings. And the data here is mind-blowing. The systematic reviews showed that interventions using wearables achieved adherence rates soaring above 80%.
80%.
Over 80%.
In clinical research, an 80% adherence rate for a sustained behavioral intervention is just staggering. Usually people just drop out of these things.
It is remarkably high. Wearables basically automate the self-monitoring process. They provide instantaneous, objective feedback, effectively serving as this omnipresent BCT on your wrist.
They completely offload the cognitive burden. You don't have to track every single Met-T or write down every exercise snack in a journal.
Exactly. However, the qualitative studies reviewed by EULAR reveal that technology is absolutely a double-edged sword.
I can see that.
Recommendation 4 actually forces providers to recognize that while a smartwatch is a powerful facilitator for some people, it can be a severe psychological barrier for others.
Yeah, the friction here is deeply human. I mean, think about it. For one patient, the gentle little buzz on the wrist congratulating them for hitting a movement goal, it triggers a dopamine release.
It reinforces the behavior, it gamifies their rehabilitation.
Exactly, it's a game they want to win. So how do the guidelines account for that?
Through Recommendation 8, which explicitly states that interventions must be evaluated over time using a combination of both objective measures from the technology and subjective measures from the patient.
Ah, so you have to marry the raw data with the human narrative.
You have to. Let's say a patient's smartwatch shows a 40% drop in total physical activity volume over a given week.
An algorithm alone might flag that as noncompliance, like, you're getting lazy.
Exactly. But a subjective check-in with the patient reveals that they actually felt the onset of joint pain that triggered the 24-hour rule.
Oh, and they proactively chose to reduce their load.
Yes. They reduced their volume to manage the flare before it escalated.
Subjectively, that is a massive victory in self-management and disease literacy, even if the objective step count looks like a failure on a chart.
That's the perfect way to look at it. The research also tackles the delivery mode of these interventions.
Like where and how the physical therapy happens.
Yeah. Recommendation 10 concludes that there is no universally superior method.
Really, face-to-face isn't automatically better.
Nope. Whether the intervention is delivered face-to-face in a physical therapy clinic, or through a digital telehealth app, or in a group class, or even just as an independent home program, they all demonstrate validity.
So what does the efficacy depend on then?
It depends entirely on matching the delivery mode to the patient's individual digital literacy, their geographical access, and their personal motivation style.
That makes a lot of sense. But, having this incredibly comprehensive map, knowing how to decouple sitting from activity, debunking the wear and tear myth, deploying FETVP, and navigating the psychology of wearables, none of that matters if it doesn't actually penetrate the healthcare system.
The translation gap. It's the bane of medical research.
Right. The task force actually acknowledged this translation gap because recommendations 1 and 2 forcefully state that physical activity promotion can no longer just be a niche specialty.
It must be standard care across the board.
Which places the responsibility on every single touch point in the medical ecosystem.
Yes. A general practitioner, a rheumatology nurse, an orthopedic surgeon. They may not have the specialized training or the clinical time to design a complex, multi-domain 50TVP program.
I wouldn't expect a GP to map out a neuromotor exercise plan in a 15-minute consult.
Nobody expects that. However, they do possess the mandate to screen the patient using a brief tool, like the physical activity vital sign, and then formally refer them to an exercise physiologist or a physiotherapist.
So ignorance of a patient's sedentary behavior is just no longer clinically acceptable.
Not anymore. And EULAR isn't just releasing these guidelines into the void and hoping for the best.
Right, they actually have an enforcement mechanism.
Sort of, yeah. They've established specific quality indicators to audit the medical community over the next 5 years. Force.
Honor them how?
They intend to survey patients directly to measure the real-world penetration of these recommendations. They will literally ask patients, did a healthcare provider explicitly discuss reducing your sedentary time? And did you actually receive a personalized physical activity prescription?
Wow. So they are going straight to the consumer to see if the doctors are doing their jobs.
It's a mechanism for holding the entire European rheumatology network accountable.
That's fantastic. Yet, despite the incredible depth of these 2025 guidelines, the task force did dedicate significant space in boxes 1 and 2 to outlining the glaring gaps in the current research landscape.
They were very honest about what we still don't know.
Yeah. The call for future research highlighted a massive disparity in health inequality, because the overwhelming majority of the 50 systematic reviews and the qualitative studies, they are drawn almost entirely from populations in high-income countries.
That's a huge blind spot. There is an urgent, critical need for data from low and middle-income countries.
Because extreme socioeconomic barriers fundamentally alter how you implement these physical activity guidelines.
Completely.
I mean, it's a crucial systemic friction. We can sit here in a studio and debate the optimal way to use a $400 smartwatch to automate behavior change techniques, or how a specialist can titrate the volume of a neuromotor exercise program. But that entire conversation assumes an incredible baseline of privilege.
It really does. It assumes the patient has the disposable income for the wearable in the first place.
Exactly. And the insurance to cover multiple sessions with an exercise physiologist, and fundamentally the safe, walkable physical environment to actually execute these exercise snacks.
If you don't have safe green spaces or you work 3 jobs, exercise snacking becomes incredibly difficult.
Another major frontier the task force identified is the interaction between physical activity and mental health comorbidities.
Yes, depression and anxiety.
Because they are highly prevalent in populations dealing with chronic inflammatory and osteoarthritic pain. Right.
Extremely prevalent. Chronic pain wears down your mental health, and the research really needs to investigate how those psychological burdens fundamentally alter a patient's ability to engage with BCTs.
If you are clinically depressed, action planning is going to be a lot harder.
Exponentially harder. Furthermore, the task force called for long-term longitudinal trials. We need to observe how highly structured physical activity interventions interact with complex pharmacological treatments and dietary changes over decades.
Not just a 6-week study.
Exactly. We need to see the decades-long interplay.
You know, all of this points to a broader philosophy that we really have to reconcile. While clinical guidelines are inherently designed to optimize the relationship between one patient and one provider, leaning entirely on the individual to optimize their movement is kind of medicalizing a societal failure.
That is a very profound point.
I mean, you are placing the burden entirely on the patient to monitor their pain, chart their fatigue TVP, and fight their own sedentary behavior. But if that patient works in a call center where they are literally penalized for standing up,
or they live in an urban environment with zero safe infrastructure for walking.
Right. No amount of personal action planning is going to solve that systemic problem.
And the researchers are actually highly attuned to this. Recommendation 4 explicitly states that addressing broader sociocultural, economic, and environmental barriers is a prerequisite for long-term success.
You cannot out-behavior change a toxic physical and economic environment.
You can't. The ultimate realization of these clinical guidelines requires integration with overarching public health policy.
It requires workplace regulations that mandate movement breaks.
Yes, and urban infrastructure that prioritizes active transport, and healthcare financing models that fully subsidize access to exercise professionals for everyone.
So as we wrap up, we are really looking at a profound, multi-layered evolution in how we treat joint pain.
A total paradigm shift.
The 2025 EULAR recommendations, they systematically dismantle that fear-based protective model that viewed joints as these fragile, inert mechanics just destined for inevitable wear and tear.
They've thrown that model out.
Instead, they demand a 24-hour lifestyle architecture. It requires respecting the distinct, independent biological dangers of simply sitting still.
Break up the sitting. That's step 1.
Right. It requires aggressively breaking up metabolic stagnation with exercise snacks. Embracing the cardiovascular benefits of high-intensity training while intelligently offloading flared joints.
And deeply integrating behavioral psychology.
Yes, to ensure these routines actually survive the friction of real life.
Ultimately, it provides the clinical scaffolding for patients to shift from merely enduring a chronic condition to actively manipulating their physiological environment to thrive.
And as we look toward the future research agenda mentioned in the text, it leaves us with a fascinating and maybe slightly unsettling prospect.
Yeah.
Yeah. The guidelines briefly speculate on the future role of artificial intelligence in delivering these interventions. Now, we know that current wearables are blunt instruments. They act as strict, context-blind coaches that can induce guilt during a flare. Right?
Very blunt, yes.
But imagine a scenario just a few years from now where a predictive algorithm isn't just counting your steps. Imagine an AI that constantly ingests your digital self-assessments of joint pain, your real-time resting heart rate, the exact duration you have been in a 1.5 MET state, the ambient temperature in the room, and even the half-life of the biologic medication you injected that morning.
That is a staggering amount of data.
And it processes all of those variables simultaneously.
Yeah.
And it dynamically rewrites your 50 TVP prescription on the fly, pinning you with the exact biologically optimal 2-minute exercise snap you need in that precise moment.
A hyper-personalized, real-time prescription.
Exactly. Would that level of automated, hyper-personalized control be the ultimate facilitator for human health? Or would surrendering the management of our physical reality to an algorithm become the ultimate psychological barrier?
That is quite the question.
It is something to consider. Because the truth is, even if you execute that perfect 45-minute workout tomorrow, you still have 23 hours and 15 minutes left to manage.